So thank you. And I know some of you may have attended the Hanoi University of Pharmacy symposium yesterday. So I'm going to repeat some of that here today, but I'm going to actually include something extra special for all of you, which is a case at the end to kind of illustrate how the new Vancomycin guideline can be implemented. Okay, so I'm going to talk about TDM for antibiotic usage in pediatric facilities. Okay. My disclosures are there. I do get funding from the National Institute of Health, so I'm going to be presenting some of the studies there. So I'm going to first briefly, you know, both of your former speakers have done a great job with providing evidence-based medicine of care and PK/PD. So I'm going to highlight just the major points here and not restate what has been done before because they did a wonderful job. I'm going to first start explaining what TDM is, as well as diving into the Vancomycin guideline because that's the hottest thing right now. That's the trend right now. Then explain a little bit how we focus on the trough before for the traditional dosing and how we're moving towards Bayesian. And I want to really emphasize Bayesian because that's a very new concept for clinical pharmacy everywhere around the world. And MIPD is essentially precision medicine. It's essentially Bayesian approach this time. Okay. So what is TDM? TDM has a lot of these nomenclature. It's known as applied or clinical pharmacokinetics, clinical pharmacometrics. But when you say clinical pharmacometrics, it implies a lot of the population pharmacokinetic modeling, meaning trying to figure out what the dose is, and the non-conformamental analysis. And I do both of this in my research. But the goal of TDM is really to optimize patient care and an individual patient. And this is how precision medicine came about. It's not just about monitoring drug concentration. You're talking about you have to get, if it's an infection, you have to get the white count, the neutrophils if needed, the CRPs, et cetera. So and of course, there's the toxicity side. So as pharmacists, we monitor cultures, we monitor whichever laboratory values that's needed to ensure the safe use of drugs. Oh, okay. So the drugs that's normally under therapeutic drug monitoring goes beyond antibiotics. I mean, we have a lot of other drugs in the United States in which we conduct TDM in the hospital setting. And there are some that's actually in the clinic setting there. So drugs that have a very narrow therapeutic index, obviously, and drugs that has high inter-subject variability, meaning from one patient to another, you're expecting a 50% change in volume or clearance. And drugs where you lack a disease response signature. So essentially, you don't have any other option besides that. Lack of response is common. For example, some cancers, we actually do TDM in the United States. And I'm not too familiar with the practice here. Also is patient with comorbidities. For example, for a drug like phenytoin, we do monitor that there, but in patients with comorbidities or on concurrent medications that have drug interactions with phenytoin, we actually get a different free level that we normally won't routinely get in the hospital setting. Of course, polypharmacy is common, especially for the NICU population as well as the PICU. And the main thing with TDM is that there's no competing drugs. Okay, and the thing with vancomycin, as well as aminoglycosides, is that in the recent years, there have been more recent drugs that covers MRSA, for example, sertraline, which you don't have here yet, unfortunately, but we use that quite a bit in the United States. And with aminoglycosides, we have other gram-negative coverage. So these are the drugs that we have TDM, vancomycin, of course, but aminoglycoside is a routine in the United States. And I think that's a very important class of drugs to implement here for clinical services. Gentamicin, Tobra are the ones that we commonly use. We reserve amikacin to the very end Generally, when we know that it's an ESBL on a very sick kid, we never use that up front. And I think that's something that requires further education here. We have anticoagulants, anticonvulsants, so seizures, digoxin. I don't think digoxin is used much here, but it is used in Taiwan. So there's tons of drugs that do require TDM besides antibiotics. So with TDM, the most important thing to remember is when we start out therapy, we use patient characteristic, and this is what we call population-based pharmacokinetic parameters. We use the volume and the clearance that we already know in the population and apply that to our patient. Once we have the dosing regimen, once we get the actual blood concentration, it becomes patient-specific parameters. And now traditionally, if we do that all by hand and on a calculator, it's considered non-Bayesian. Why? Because we're only using the actual patient's actual concentration. That's inferior. That means that's not as good as Bayesian. Because Bayesian, as I'm going to explain, I believe in the next slide. Oops, all right, let me go back. Bayesian method here requires that we integrate a priori data as well as the a posteriori data. So we combine both of that information to get a Bayesian estimation of either AUC, trough, or peak. Okay, so Bayesian is always superior, and that's very important to note. Here's a very important slide. Oh, just skipped on me. Okay, here. Here's a very important slide, especially when you at an institution where you don't have a software program to use. You generally start out here. Essentially, PK, there's 3 models that you can use for TDM. Either continuous infusion model, that's the one that you use for drugs with very long half-life, or have sustained release, for example, formulations. The other 2 models are intermittent infusions. That means you give it every 6 hours, every 8 hours. And of those, there's 2. Am I talking too fast? There are 2 models. There is a short infusion model, which is the most conservative. So if you don't know which model to use, you use that model, the short infusion model, because it's most conservative in estimating clearance and volume, which is what you want to do in your neonatal and pediatric population. And so this is just an algorithm that kind of goes through which model you would use. So this is an important slide to have. The hardest model to use is the short infusion model, because what happens here is that you actually get some drug clearance during the infusion time. So when you're using this for vancomycin, for example, you would expect to see some drug clearance during the infusion. And let me see which part. This part of the equation here accounts for that. I know it's kind of hard to think, wait a minute, how can it be going out when it's just going in? But that's what the model assumption is about, okay? The other thing here is that most of these models that you use, it assumes that you achieve steady state. When you're not at steady state, it's called iterate, non-steady state. This is much harder to do, okay? And I usually don't teach this until a student asks me to. So just brief comment about the Vancomycin Guideline. Remember, there were no pediatric information in 2009 when the guideline first came out. And that was the problem, because what ended up happening is we used adult levels of 15 to 20 trough and used that in pediatric. And so what happened with that was an increased incident in nephrotoxicity. I mean, the patients, some institutions were using 90, 100 milligram per kilo per day. And if you go to the literature, you're going to see some institutions reporting that, which is appalling because it increased nephrotoxicity significantly because we were using trough. But the new guideline, we have a lot of more PK/PD model that have been published, focus more on just the PK/PD, not outcomes data, just PK/PD, largely just for dosing, because we know that's something that we can do easily with vancomycin. Outcomes data, very hard. One, because MRSA incidence in the United States, for example, the bacteremia, the pneumonia is actually decreasing. We don't know why, we can't explain it, but we're seeing a decreasing trend. So it's much harder to get outcomes data in those population because you're going to need essentially 100 institutions to be able to collect even 100 patients, or you need 100 years to get the data that you need to have an adequate sample size for analysis. So just quickly there, we know the AUC to MIC assuming of 1, because 95 of the isolates that we see out there has an MIC of 1. So if you assume 1, we're good. And this can be through the Vitek 2, Phoenix, or the microscan. It does not need to be e-test, okay? You make that clear. It does not need to be e-test. So with pediatrics, you always want to aim for the lower end, 400. If the patient's 380, 390, okay, it's pretty close enough. In fact, the original data study that had this had a margin of 380 rather than 400. She just ran up to 400 because it was easier to remember. But it does integrate Pediatric Infectious Disease Society, which John Bradley, a good friend of mine, was on that and got that through. And so the guideline clearly says trough monitoring not recommended, okay, because we can do a lot through AUC. It doesn't mean you can't do trough concurrently with AUC, but the focus should be on daily exposure, not a single point in time. Also, too, the guideline emphasized serious Staph aureus infection, really serious MRSA infection. If the patient doesn't have that, culture negative, you don't need that. You don't need this aggressive dosing. Okay, you don't need to achieve 400 AUC, the MIC 400. If the patient's responding and it's a MRSA, no, let's say it's MSSA, you should be switching out to an MSSA agent. Of course, Bayesian estimation, that include at least 1 trough level. Now, in scenario where you don't have a Bayesian software, you need at least 2 levels, not 2 troughs. A peak and a trough, because 2 troughs is not going to tell you the elimination rate constant. It's only going to tell you just really as it's inferior. It's not going to give you a good sense of volume, essentially. And you can draw it before steady state. Before, you had to wait usually after the 3rd or 4th dose for neonates and pediatrics. Here, you can actually get it after a day, one or two doses. And again, assuming MIC of 1. And this is the data that was responsible for an MIC of 1 here. And this was over many, 150,000 isolates around. I think this was largely focused on the United States and maybe some European countries, but I'm not sure if it covers Asia. Key recommendations there. So again, aggressive dosing only for MRSA. And also patients at risk for high nephrotoxicity, critically ill, those are on other potentially nephrotoxic agents should be monitored more closely and TDM being conducted. However, if the patient is on less than 3 days of therapy, you don't need to conduct TDM. So that's why the majority of kids in the United States, we don't even do TDM. If they start out empirically and we know they're not that sick, we don't even do TDM. Okay, so that really reduces a lot of work for the clinical pharmacist to focus on other things. Just quickly on AUC, the MIC data, this is my friend Pamela who conducted the original research on why AUC of 400. And she was able to demonstrate faster bacterial eradication. And this was Staph aureus pneumonia model in actual patients. This was not an animal model. This was an actual patient. And she was the first one who started this and selected 400. So here, let's say, so far we were able to show strong affiliation, association between vancomycin AUC and treatment effectiveness. Trough alone should be used to assess the risk of acute kidney injury per guideline. Does anyone know that? Did the guideline talk about, okay, if you're going to dose by AUC, but if you're going to look for nephrotoxicity incidents, go with trough? No, the guideline did not say that. So this is false. In the one of the first study by Tom, who was part of the guideline representing, I think he wrote the nephrotoxicity section. He was the first one to show that in adults, 4 grams or more increases the risk of nephrotoxicity. 4 grams or more is about greater than 60 milligram per kilo per day, essentially in pediatrics. And subsequent to that, a lot of studies actually found something similar related to trough of 15 to 20. Okay, we know that higher troughs, which is what was recommended in the original guideline, increases nephrotoxicity. And back then, the United States didn't believe such. They said, no, it's other things. It's ICU stay, it's furosemide use. But this meta-analysis proved that there is definitely a higher risk, 2.76 higher risk, about almost 3-fold. So that was trough. We got recent data to actually associate AUC to nephrotoxicity. And this was one of the first study by Zazowski. I think this person's from Mike Ryback's lab. But essentially, we were able to show that the upper limit in adults was about 700 milligram per kilo. So if the therapeutic target is 400 to 600, you want to keep it around there, because above 700, you're going to see increased risks for nephrotoxicity. And even pediatrics, I think I published, yeah, I did publish a paper. Oh, but I didn't put it in here. I published a paper that looked at this in pediatrics, and we have, like, I think the AUC was about 800 using CART analysis and using multivariate modeling. So I'm comfortable with the 800. And subsequent to that, we have a lot of literature here that confirm this finding, that there is an association of nephrotoxicity to AUC. And what's interesting about these studies too is that, well, how do we estimate those AUC? Here's 2 level that use the trapezoidal rule, which essentially means non-Bayesian. Here's 2 level, and with 1 level, you can use Bayesian. And that's how we came up the guideline recommendation. 1 level must be Bayesian, 2 levels, non-Bayesian, okay. But ideally, you want 2 levels with Bayesian, if possible. Okay, in a patient, peak and trough concentrations were measured. So we have 2 concentrations. Since the software was unavailable, the short infusion model was used to determine clearance to estimate the non-Bayesian AUC. After analysis of the measured concentration, the dosing interval was revised from every 8 to every 6, so more frequently, okay? However, the total daily dose was unchanged. So here's a patient who's on 60 milligram per kilo per day, still on 60 milligram per kilo per day, but just changed from, I guess, 20 every 8 hours. Is it 20? Yeah, to 15 every 6 hours. Okay, so does both the AUC and the trough value change? Is the question. And these are the formulas that are used. This AUC is just dose over clearance, and this is the short infusion model. The answer is only the trough changes. If you're looking for exposure over a day, if the dose did not change, then the AUC is not going to change. And this is a very important concept, okay? But if you were to change the dosing interval, if you give it a longer time to decay, it's going to be lower trough. So you're going to see changes in trough. And this is exactly why we switched over to AUC, because it's more consistent from day to day. Okay, which of the following is true for Bayesian estimation? Is it a tool to use associate drug exposure to efficacy, which is A, or to safety, which is B, or C, integrates a published PK model with current patients' dosing history as well as drug concentration, predicts best dose to plan for a PK study, or E, relies on patient dosing history and drug concentration? In the interest of time, I'll give you the answer. It's definitely C. Bayesian is all about bringing in a published PK model and using some of that information to estimate your exposure, okay? That's the key point with Bayesian. And so selecting the published PK model is very important. That has to match your patient population. So neonate will have a different model from a pediatric patient, and the model that you select will have to be based on if it has serum creatinine value as an estimate for clearance, you have to figure out if that serum creatinine assay that you have is consistent with what the study used, because the value is going to be different. Just again, reiteration, Bayes analysis has this a priori data. Pop PK, we need that. It cannot just be based on dosing history and measured concentrations. That's inferior. So a new concept recently, I think last year, 2 years ago, there's something called model-informed precision dosing, which is essentially using Bayesian estimation. That's all it is. Okay, you apply it to Vanco, but it's a more of a clinical decision support. Okay, if you have this, what would you do? And there are the gist to all of that is you need expert clinical pharmacists to be able to do this, because without it, it's going to be next to impossible for physicians to do this, because they are already so busy with taking care of patients and nurses, diagnosing particularly amongst physicians. So the clinical pharmacist is utmost important. And these, I will refer you to these publications there that goes into more of these, but essentially it's just Bayesian estimation. And so in selecting what the best software is for your patient, I would say it's these two here. Using the best model that fits your population is going to be critical. Remember, even if you choose the best model, you may still see 50% variability. So most likely 50% of your patients, you're going to need to adjust the dosing, okay, because there is that variability. And there are some models that are for obese, and obviously there's models for neonates, but recently there's stuff for neonates. There are some PK programs that actually distinguishes ICU and stable patients, which I find it intriguing. I don't know what they program behind it, but it's certainly something that is worthwhile to try. But I don't think any of this integrate the concept of augmented renal clearance as been presented earlier, because that's very new. It came from adult literature from Australia, but we're actually seeing that reported in infants, well, particularly pediatric patients greater than 3 months. And here, I would refer you to this publication here that was published recently by one of my former students that kind of reviews not just the different software, but also the population-based PK model. Go through that and see there's a reason. So InsightRx and Precise PK has most of the models. It has, I'm sorry, let me see here, the pediatric as well as neonatal model. Okay, so here you can actually select what you want and use that for your population. So I'll leave that up to you too, but this is a very good paper to reference if you're considering that for your institution. Quick case study here. We have a 7-year-old female on Vanco for skin and soft tissue infection. Remember, this is a skin and soft tissue infection. Serum creatinine of 0.2, height of 129 centimeters, weight of 28.8. Empiric dosing. So when we start out therapy, you have to use a pop PK model. Pop PK model, if you know volume and if you know clearance, then you should be able to get the dose, right? Because volume and clearance are independent parameters. So if you know that, so we estimate this using the model that I published in 2013 that has the largest sample size to date for this age range. It was 3 months to 21 years of age. So we do that, and then from that, once we have volume and clearance, you can figure out all the other PK parameters. And then from the half-life, you can figure out what is the best half-life. So usually for vancomycin dosing interval, we dose 1 to 2 times the half-life. So if you find out the half-life of the patient, then for this patient, it seems like every 6 hours is better than every 8 hours. And so after you have that, you can calculate AUC, that's the goal that you want, and you just plug in this formula to figure out what's best. So it's pretty straightforward. Okay, and then I usually routinely confirm what the trough, I know the guideline says no trough, but I always do it, it's a habit, what the rounded dose would be. So I just go through that using the short infusion model to figure out what the trough would be. So in this patient, we're getting a AUC about 470 and a trough of about 9. And this is an actual patient, by the way. I don't know what the clinical status is. I don't know if there's more seriousness to this infection, but in any case, the patient was on this, and on day 2, we got a level at 7 o'clock that measured 7. And now we only have one level, right? So one level means we need a Bayesian tool. But I don't have that right now for demonstration, so I'm just going to do it non-Bayesian way. Generally, when you have one level, you have to iterate, and that's very difficult to do. But here I did ahead and iterate for K using the shortened fusion model. If you go by that study by Han, it goes through all of these steps for you, okay, to be able to calculate this. So there's a table in there that takes you through each of these steps. So you can practice on your own. Using that, this is essentially what we get as revised, a rate constant, clearance, and we were expecting a level, I believe, of 9, but here, when we actually measure based on one trough concentration, it was about 8. Okay, pretty close, but a little bit different. So we keep on iterating. Our level was 7, right? We got a level of 7. So we keep on iterating. We keep on guessing what the K is until we get to the 7. So this is the iterative process. It's very time consuming. So you really need an Excel file, something that's established within your institution to do this. And if any of you need that, let me know. I do have an Excel file that you can use for the non-Bayesian. I can't give you the Bayesian, unfortunately, because that usually comes with big dollars. But Hai Lei from the Hanoi University of Pharmacy, he is in the process of developing a software that's Bayesian, and he's integrating neonatal and pediatric models in this. And so once I'll be working with him to test it out, and once that works, he's going to make it available for every institution for free. So go ask Hai Lei from Hanoi. It's a great public service to all the hospitals. So I'm glad he's doing that. But this is what iteration is. It's very long and tedious, but it is possible to do. So you keep on going through that exercise until you hit a level of 7. And so once you have that, you can figure out all the other PK parameters. And for this patient, it comes out to be 411. For the patient-specific AUC. I know I'm going through this really fast, but let's move on. So in this is a different case, but I just wanted to illustrate to you the difference between Bayesian and non-Bayesian. So here we actually have, I believe, 2 levels, and putting in, the dose and the level concentrations. The area under the curve that you see here with non-Bayesian was 400, with Bayesian is about 300, okay? Generally, you'll see the opposite. I know this is not the best case, but you'll see the opposite where Bayesian is usually higher. You achieve those targets better. But this is a scenario where the patient is clearing a little bit better, or the volume is different. So it's usually one or the other that's contributing. So if you look here at the clearance, the patient here is clearing a little bit better using the Bayesian side. That's why the AUC is a little bit lower. And there's shift in volume as well. So I refer you, this is a good table to have. This gives you all the PK model you will need to know for patient care. And each drug would use this. So for vancomycin, we use one of these 2. This is what we would use for sustained release of valproic acid. I don't know if you guys use this here. For seizure control, digoxin, anything that has a sustained release or product or long half-life we would use. But most of the time we use this. Other equations listed there. So key takeaway. The whole goal of any pharmacotherapy is really to use the minimum effective dose, especially in pediatric patients, right? You don't want to use more than what is necessary. Pediatric and geriatric patients are what we call vulnerable populations in the United States. So we're very careful. So the goal is that. So any guideline you see, just use the bare minimum as possible, especially for vancomycin, because we still don't have outcomes data in pediatrics, definitely not in neonates. And with the incidence decreasing, we definitely want to be more conservative. We can still use what we know of adults outcomes data for pediatric because the disease pathology is the same, and the FDA recognizes this. The FDA recognizes that we're never going to have enough patients to show outcomes data in pediatrics. So we can use what we see in adults and just do PK, clinical pharmacology, to be able to dose it properly, but still achieving adult target attainment. And avoiding anything higher than this, obviously, and using decision support tool, if available, to conduct TDM.